Now I call upon the next speaker, Dr. Kapil Nagaraj sir, surgical gastroenterologist of Apollo Hospitals, to talk on chronic liver disease, liver transplant.
First of all, I'm privileged to be here, and I thank the chief guest, Professor Ganeshan, for obliging to come here for the event. And he has also been my mentor at some point of time, even though I'm a surgical gastroenterologist. And thank you, sir, for coming. And I thank you, Vijay team, for the opportunity again. So initially we discussed about having a debate, but then we realized there's no debate for transplantation. So we said we'll just move on with the topic. So the outline is going to be, we're going to discuss few topics of transplant. It is not going to be an entire topic on how it is done or technical things, because the crowd is more of a medical gastro as well as general physicians and surgeons. So we just look at the shifting etiology trends. So what the world is saying is that there is a shifting etiology towards more of an alcoholic and a MAFLD causing cirrhosis. And previously it was hepatitis B, C, which are actually there is a downward trend. And also because of the improved vaccination drive, which we see for hepatitis B. And the other thing is the obesity is on the rise, so MAFLD is going to rise with other metabolic diseases. So this is also the similar pattern in the West with MAFLD is the fastest exponential growing indication for transplant, and ethanol follows it again. So when it comes to survival benefit, let's look at the natural history of cirrhosis. There is a decompensated phase and the compensated phase, which my previous speaker highlighted already. So the survival actually is about 10 years to 12 years for a compensated cirrhosis, whereas it comes down, but with the first decompensation, it comes down to about 1 to 2 years. So after the first decompensation, it's usually a path towards transplant if you expect a survival for these patients. So there are certain mitigation strategies when it comes to a compensated cirrhosis, where you can delay these patients to move on to have a first decompensation, such as if the patient is an alcoholic, you can ask him to have set stop alcohol, or if it's an obese patient with a MAFLD, we can advise a bariatric surgery, and now we have that we have drugs to do the same. And we also should effectively manage the hepatitis B and C, and of course control of diabetes comes in front. So the survival benefit is established. It is about 5-year survival of usually 70 to 70% in any alcoholic or any liver disease. We also have a long-term life expectancy to the tune of 10 to 20-year survival, which goes up to the tune of 60%. The survival benefit or the life years gained increases with the severity of the liver disease. With high MELD scores, we look at a better benefit for surgery. And the factors which are influencing the life expectancy are the basic condition of the recipient at the outset, whether he is a good candidate for transplant, and other donor factors as well. So we also looked at the Indian scenario where the survival, where the survival is about same. 1-year survival is about 84% and a 10-year survival of 72%. And the more important point when it comes to going to skip this. So when the MELD score is below 11 is what we don't see the benefit of a transplant. So we keep the MELD score as 11 and above for considering them for transplantation. And we'll go into the discussing about MAFLD. This is the fastest expanding indication for liver transplant. It's about 10 to 20% of transplants in today's scenario. And there is also an incident increase in HCC in these patients, unusually, because they're over 80 to 137%. This is possibly related to the genetic polymorphisms and the insulin obesity and the insulin resistance. And these patients are much more naive, and we need to give more concentration on their pre-transplant optimization as well as post-transplant care. And the hepatogenous diabetes associated with MAFLD is usually reversible with the transplant. And so we need to also consider tailoring the immunosuppressive therapy for these patients, because steroids can again put them on significant hyperglycemia for prolonged periods, as well as tacrolimus, which is usually an immunosuppressive drug which is given for post-transplant maintenance. So also we should understand that the recurrent MAFLD and or de novo MAFLD in the graft. Recurrent MAFLD is nothing but a patient who had transplant for a MAFLD again develops malformity in the graft because of the non-compliance to lifestyle modification and diabetes control. Whereas the de novo malformity is in a graft which happens, a patient underwent transplant for some other reason, etiology, and then subsequently it develops malformity in the graft. So this is something to be understood. And we also give significant importance to the cardiac workup in these patients because they have significant comorbidities such as cardiovascular disease as well as any cardiovascular disease. So we need to do a thorough detailed cardiac evaluation for this patient pre-transplant. And we also should, we thought the more important point to discuss in a post-transplant scenario is the risk of recurrence of hepatitis such as B and C. So when it comes to recurrence, it is because of the long-term immunosuppressive drugs which we advocate for, reducing graft rejections. And the recurrent HBV infection is not of concern because we have effective antiviral drugs for the same. Whereas recurrent HCV is usually common, and we do have drugs for the same. But there is always a diagnostic dilemma when it comes to HCV because graft rejection mimics recurrent HCV infection. And this is regarding hepatitis B. The more important point is that if a patient has a cadaveric recipient, and the donor, the cadaveric donor has a core antibody positive, which is routinely done in all pre-transplant evaluations. Whenever we harvest the organ from a donor, we usually see for core antibodies, and these core antibodies are going to be positive. There is high risk of recurrence of hepatitis B infection in the recipients. So hepatitis C, there is a near universal reinfection for these patients, and we have effective drugs, directly acting antiretrovirals. They have sustained virological response irrespective of genotype. And transplant HCC, yes, this is a specific discussion topic which can be discussed for 3-4 days. We have the initial survival rates of 60 to 70% for these patients within Milan criteria. Now with the expanded criteria, which we are still having a good response, the results are about 50 to 70% for these patients too, with beyond UCSF as well. So also that we need to understand that some of the patients who have beyond Milan can be downstage to Milan, and then subsequent transplant can be done. And the biological criteria are more important, and nowadays with the advent of the transplants are being advocated for more HCCs which were previously considered non-transplantable, and so the biological criteria is taken into account. And these include the AFP and histological grades. If you see the criteria listed here, most of the beyond UCF criteria consider a biopsy for these patients to look at the biological grade, because that indicates the risk of recurrence for these patients. And the post-transplant recurrence in these patients is again 8 to 20%, usually occurs within 2 years of transplantation, and this can be assessed by a risk estimation of tumor recurrence after transplant, retreat score, which is based on alpha-fetoprotein, microvascular invasion, and the largest active tumor length. And now within transplant for cirrhosis, the most deadly one is the ACLF, which has a post-transplant mortality of about 30-40%, even with the best of candidates with ACLF. So what is ACLF? An acute hepatic insult manifesting as jaundice, serum bilirubin more than 5, and a coagulopathy, which is complicated by within 4 weeks by clinical ascites and or encephalopathy. So the more important is that these patients have a high 28-day mortality. So the key differences with EASL CLIF definition is that the primary organ involved is the liver in this case, whereas in EASL definition it's the organ, extrahepatic organs are also considered, and usually sepsis is a sequelae of organ injury. So the initial insult in ACLF in cirrhotic patients is usually a flare-up of hepatitis B in hepatitis B related cirrhosis, or an alcohol abuse, or a drug-induced liver injury in general cryptogenic cirrhotic patients. So APASL basically is more inclusive, and we have golden window where we can identify these patients early and treat them aggressively. So we can mitigate the primary insult. For example, if it's a flare-up of hepatitis B, we can give them antiviral drugs and mitigate the primary insult, thereby giving a remission to this patient. And the timing of transplant, yes, it's very debatable. When patients have a high scoring ACLF, generally they become fertile. So we need to time the patients, time the transplant even before they go into that stage where there are multiple organs involved. And yes. So now we just look at few topics about the cadaveric and the living donor transplant. The most important topic when it comes to mind is the organ shortage, which is universal, and we have certain mechanisms to improve the donor pool, which are either cadaveric donors, wherein it's an opt-in or an opt-out policy. We'll also discuss about marginal donors and a GRW ratio, and ABO incompatible transplants, swap livers, altruistic donations, and organ trafficking, which is not the ethical or illegal thing. So, looking quickly at it, generally it is in the countries like India, we have an opt-in policy where we can come forward to donate the organ. But whereas in countries like Spain, Argentina, and UK, which is adopted lately, we have an opt-out policy where all the potential, all people are usually considered as potential donors, and whereas they have an option of opting out. But it's called a presumed consent, where it is considered they are potential donors, and it increases the organ supply. But there are certain criticisms such as losing of autonomy and loss of trust for the doctors community, and there are some ethical concerns. So when it comes to marginal donors, we have started using marginal donors such as old age. Even the sectarian donors have been considered. And we all start accepting even very steatotic livers up to 15% to 20% of macrosteatosis. Of course, with adjuncts such as organ perfusions machines. And we also have considered DCD livers lately, but still not very upcoming in India. And we have continued to do core antibody positive donors and HCV positive liver grafts and split livers. And when it comes to living donor transplant, the most important concept is at the GRWR and the risk of small for size syndrome. GRWR is nothing but a graft to recipient weight ratio. It's a critical metric in living donor transplants. Usually a pointed standard is considered standard to reduce the risk of SFS. But then we are looking at strategies to reduce the GRWR thresholds. Like for example, we consider mitigation strategies such as portal vein modulation. The most importantly done procedure is a splenic artery ligation. And now we are starting to do ultra low GRWR transplants. The recent publications have kept the threshold less. And now routinely it is that living donor transplants are considering 0.6 to 0.8 as the thresholds for the GRWR. We also taken up ABO incountable transplants due to the reason of organ shortage, and this is possible with advanced immunomodulation and desensitization protocols with the plasma exchange and rituximab. The target titers are for transplant are 1:8 and 1:16. We usually do repeated plasma exchanges to get this point and then subsequently consider transplant for them. And swap liver, yes, if there are two different families with two different donors and recipients, if they have size mismatch or a ABO incompatibility, we can do a swap liver transplant. But this is there is a logistical complexity associated with this, and size mismatch complicates the scenario. So finally, I just wanted to finish with organ trafficking, and there have been a lot of movies on organ trafficking recently. They started with kidneys, they have moved on to the livers, and then now I think it's heart is going on now. So this is illegal, and this has been routinely done in China from 2000 to 2010, which is actually proved beyond doubt. So it has become an organized crime in several parts of the world. This also has actually a strategy to reduce organ shortage for the criminal world. And to summarize, I would just say that there is a definite hope of survival for the transplant for DCLD patients. The only problem here is the donor, and if probably by policy changes such as an opt-in, opt-out policy for the entire country, we may end up with having a more cadaveric programs which can reduce the organ shortage. Particularly if you see within the country, there is a huge divide between the south and the north. We have a robust cadaveric program in the south, particularly in Tamil Nadu, whereas in the north, It's a completely living donor program, and this difference can be removed if with a probable policy change in the government level. Thank you.
And patients with fatty liver, they can be donors as well, right?
Yes.
Yeah. So, how do you, ideally, it should be a good liver. How do you optimize these patients before becoming a donor, and how do you assess them?
We do a MRI assessment as well as the CT assessment, and of course, if they fall into the good volume and there are no arterial or venous problems which we face, then we put them on a strict diet plan for at least 3 to 6 weeks. And nowadays it's like very short, like we just do it in 3 to 4 weeks. No, we biopsy them if there's a MRI quantification is very high, like more than 10 and all that. But we don't usually do. We go ahead with the transplant if their liver looks all right. The fat is not beyond 10 to 15, yeah. For a living donor. For a cadaveric, I think our thresholds have gone up. Like we consider macro up to 20% to 25%.
In living donor liver transplant, our Indian surgeons have any new criteria for HCC in CLD patients beyond UCSF. I think
yeah,
Vela sir and Medanta group, they are having their own criteria. Is it how much?
They have a very good downstaging program, so I think they consider all livers for transplant.
Yeah, they don't follow actually UCSF or Milan or extended criteria. They have their own criteria.
Yes.
So I think our medical gastroenterologists must refer cases accordingly.
No, I think with the aggressive downstaging, I think they're able to transplant livers, but
I want to know any particular criteria they have formed or anything like that.
Science says for everything. Like there is no 10 centimeter criteria. It was initially 10,
yeah, I know.
But then there's no 10 also now. So
that's what. How the results? Any
I think it's transplant for all.
Yeah, any results?
I think the only contraindication is the extrahepatic involvement.
Okay.
That is the only contraindication. Otherwise.
No, I want to know about the results. You have any idea how
they are actually proposing that their results, but it's not published yet. Like their protein, beyond UCSF and beyond, they have not published their results yet.
Not yet published yet.
Those with other than Milan and UCSF, sir, they are doing high chance of recurrence is there actually. Recurrence is the problem.
No.
Definitely the survival improves. The patient tend to live 2 to 3 years more than those without transplantation.
Compared to West, we have robust data here, and we are doing more living donor transplant compared to the Western countries, sir. So we are still following the UCSF and Milan criteria. Our surgeons like Dr. Reela and Dr. Soin have extended the criteria, and they have shown good results in conferences. They have not yet published the results because we are going to a lot of conferences. They are showing the data actually. In living donor, I think we are pioneers. Asians and Japanese and Indians are pioneers compared to the Western people, where they do very, very less number of living donor transplant, and we need not have to follow their criteria for our patients. Actually, we have to devise our own criteria. Maybe in future it may come. Right now we are following only UCS of Milan, but I think it may come in.
Sir, what I am telling is, it's not about not doing the transplant. We can do, but there is a high chance of recurrence. That's what I am telling. Recurrence of HCC.
Yeah, that is it. That has to be explained to the patient and understand.
When it comes to cadaveric program, it is very important that you consider.
Yeah, only for living donor program.
For living donor program, I think they are extending and proceeding to transplant.
As far as HCC is concerned, I think there is one clear rule. If the alpha fetoprotein is more than 1000, I think they don't transplant, because the recurrence rates are quite
so they downstage
very high.
Very high.
Even if we downstage also, the recurrence rates are quite high.
It's a controversy.
I don't think they take up for transplant. They probably use methods to probably loco-regional and then probably see whether survival improves.
I just want to put a word that now they are doing beyond Milan UCSF also, so that we do not deem the patient inoperable and go for other methods. We can have an opinion from the transplant surgeon before that. So that I think the patient has to be discussed
for that
before
patient,
branding the patient inoperable.
Agreed, sir, but for that patient, if that additional 1 year or 2 years survival becomes important to that family, then I think they are...
Before branding them inoperable or nothing to be done, a consult can be taken so that it will be helpful for the patients.
Kapil is talking about 1 year, 2 years survival. But as far as the oncologist is concerned, even a 3-month survival is good for them. They say the patient can sign a will can do anything in 3 months.
Yes,
So for them, 3 months survival is good enough.
Most of the patients we see, those will be present in portal vein thrombus.
that is it. That is vascular invasion is inoperable.
Like,
That's no.
You're doing patients with portal
They are
tumor
doing up to
invasion.
VP2, sir. They are doing.
They are doing.
They are doing after downstaging with either stereotactic radiation or trace or tear. They are still considering transplant for this patient.
We will transplant anything. Okay, sir. Good.